cholesterol at 280 mg per dl, and the doctor starts atorvastatin 40 mg. But 3 months later, cholesterol is still at 260. So why did the statin fail? The answer is in this one doodle from Dipiro Pharmacotherapy. Hi guys, welcome back. I'm Shifana in Zen with Shifana, and today we will decode the causes of dyslipidemia, the primary versus secondary. And plus, if you are patient, knowing the causes is equal to knowing the cure. Watch till the end. I'll give you some Dipiro's golden rule that 90% of the Indians forget. Primary, if you see, it's familial hypercholesterolemia. Okay, so it's FH if you see in short form, and where the LDL receptor is like a key and lock, where LDL particle has ApoB, which is act as a key, and liver cell has this LDL receptor, which acts as a lock. In FH, the gene mutation in chromosome 19 breaks the lock. So, in the result, the liver cell is obese and unable to process the LDL. So, the LDL stays in blood for weeks instead of hours. So, LDL becomes more than 190 mg per dl from the birth. This is autosomal dominant. If one parent has it, 50% of the chances where the babies also will get. So, what will the treatment for this? It's nothing but high intensity statin plus PCSK9 inhibitor, which I have already said in the previous video. Then comes the ApoB defect or familial defect ApoB, where ApoB 100 is the ID card for the LDL. If the ID card is malformed, the liver says, I don't know you. Hence, I drop PCSK9 mutation over here. So, PCSK9 normally destroys the LDL receptor. So, when there is a more PCSK9, which means hungry LDL receptor will die. So, less receptor is equal to more LDL, obviously. Then comes the familial combined hyperlipidemia. When the liver overproduces both LDL plus VLDL, also defect in the LCAT enzyme. The LCAT enzyme is nothing but lecithin cholesterol aryl transferase. It helps mature HDL. So it means the defect is equal to bad HDL plus bad LDL. So here is a key for Viva. What are the primary causes? It's nothing but it starts in childhood, family history of MI with less than 55 years in male and less than 56 years in female, and tendon xanthomas. And statin alone won't normalize it. We need a combination therapy. Now comes the secondary acquired causes. Okay, where the 80% of rule is over here. Now, the 80% of the patient in hospital posting have secondary hyperlipidemia, where it is given in the Dipiro book, and there is a good news in it. The treat the cause will normalize the cholesterol without high dose in statin. So what you have to do, just treat the cause. So in this we'll see what all will cause the secondary type of hyperlipidemia. First is the diet and lifestyle. Okay, here I have shown obesity, saturated food, alcohol, and no exercise. The mechanism acts like this. When there is the excess carbs, liver makes more VLDL. So more VLDL converts into LDL. And also when there is more alcohol, there is more triglycerides. And where is saturated food, there is less LDL receptor. So this is the metabolic syndrome. So when you have a fixed diet plus 30 minutes walking, obviously the LDL will drop by 15 to 20%. Then comes the drugs. This is where PharmD saves the life. And Dipiro lists three main drugs. One is diuretics, beta blocker, then will be the glucocorticoids. And diuretic like HCTZ will increase the LDL and decreases the HDL. Why? Because the volume depletion in the insulin resistance. Then comes the beta blockers like atenolol. Slowed heart will be there. So where there will be decrease in the lipoprotein lipase and which eventually increasing the triglycerides. And comes the glucocorticoids. Steroids increases the VLDL production in liver. So patient on prednisolone will always have a high triglycerides. Then comes the medical conditions. where DM is there. Insulin resistance will cause the free fatty acid increases, and where the liver makes the VLDL because of it. That's why diabetes patient get atherogenic triad, that is high triglyceride, low HDL, and small dense LDL. Then comes the condition hypothyroidism. Guys, even I also have hypothyroidism, so I may to get hypercholesterolemia. It's okay, leave about that. So hypothyroidism. TSH high is LDL receptor down. So patient with TSH 20 will have LDL 200 even on good diet. So treat hypothyroidism first. Then comes the CKD plus nephrotic syndrome, where the kidney leaks the protein, so causing the liver compensate by making more lipoproteins. So nephrotic syndrome will cause the more amount of triglyceride, about more than 500 mg per dl. Then comes the liver disease, that is cholestasis, where the LDL, that is LPX, increases. Then comes the cholestasis, that's what I have written. The bile flow will be blocked and cholesterol can't secrete. And last, it comes the pregnancy and menopause. Estrogen drops in the menopause, where due to that, LDL receptor will be decreasing. So, pregnancy in the second trimester, the triglyceride doubles. So, usually it is reversible after the delivery, so it's okay. So, as I said before, here is a Dipiro's golden rule, guys. Rule out the secondary causes before starting a lipid lowering therapy. If you miss hypothyroid and give statin, patient plus doctor will what they will blame? Of course, they will blame the statin drug. Also, with this, I'll give you a quick recap. For primary will be genetic, that is FH, ApoB defect, and early onset family history xanthomas. Yeah, and secondary, here is the memory trick, that is health D. Hypothyroid, estrogen deficiency, alcohol, liver, thiazide, health diseases like DM, CKD drugs, uh, and drugs like steroids. And if you guys are going to an hospital, posting in a hospital, I'll give you a small tip. Before writing atorvastatin, what you have to check? Of course, you guys have to check for the TSH, FBS, urea creatinine, LFT. So that's the Dipiro's protocol. If you found this doodle helpful, and this is how I'm also studying right now. So complex topic into simple drawing, which will be never forget. So subscribe my channel and comment below which causes surprised you the most. Is it the beta blocker causing the high cholesterol? Okay, comment PDF. I'll be sending you the PDF of this notes. Bye. See you in the next video.